Welcome to this explainer. Look, if you're a neonatologist, you already know the NICU is an incredibly high-stakes environment. Managing a seizing newborn requires rapid, pinpoint decision-making because, well, time is quite literally brain tissue. Every single minute of uncontrolled epileptiform activity carries weight. So today, we're taking the latest clinical data and translating it into a highly focused, actionable diagnostic framework to help you navigate exactly that. Let's get into it.
So, let's dive straight into this clinical challenge. We all know the drill. Roughly 90% of the seizures you see on the ward are acute symptomatic events, right? They're provoked by something obvious like HIE, a perinatal stroke, or an acute metabolic derangement. But what happens when your patient falls into that rare 10% of unprovoked seizures? Picture the anxiety of staring down a completely negative MRI, totally normal labs, and yet the infant is still having continuous refractory seizures. The diagnostic waters get notoriously muddy there, and that is exactly what we're going to clear up today.
Here is the diagnostic funnel we'll be using. First, the clinical objective. Second, ruling out provoked seizures. Third, self-limited neonatal syndromes. Fourth, epileptic encephalopathies or DEEs. And fifth, treatable metabolic epilepsies.
All right, Section 1, the clinical objective, precision in diagnosis. The big takeaway here is that nailing down the exact etiology of a neonatal seizure isn't just an academic exercise to make your chart look complete. Identifying the exact genetic or structural cause directly dictates your therapeutic pathway. It literally determines whether you immediately reach for a sodium channel blocker like carbamazepine for a confirmed KCNQ2 mutation, initiate a very specific vitamin trial for a metabolic defect, or sit down to counsel the parents on a potentially devastating neurodevelopmental trajectory. Precision in your diagnosis equals precision in your management. It's really that simple.
Moving right along to Section 2, ruling out provoked seizures, which make up that massive 90% majority.
You can clearly see the massive divide here between acute symptomatic causes, like HIE, arterial ischemic stroke and intracranial infections, versus actual epilepsy etiologies. The golden rule? An exhaustive workup for these provoked causes is absolutely mandatory. You have to do this even if the family history is practically screaming benign neonatal seizures at you. Why? Because it's dangerously easy to anchor on a family history and totally miss a subtle intracranial hemorrhage or a brewing infection. Acute provoked seizures are way more common, and they need early, specific treatments to stop ongoing brain injury. You absolutely cannot skip this step.
To safely filter out those provoked causes, your workup needs to be highly systematic. First things first, check for the immediately treatable metabolic stuff. Think hypoglycemia or hypocalcemia. Next, get a continuous EEG to confirm you're actually dealing with true seizures, not just benign sleep myoclonus. Then, get that brain MRI. That's essential to narrow your differential and rule out structural issues. Finally, if the history, exam, and imaging are all coming up empty, it's time to seriously consider rapid genetic screening. In modern NICUs, shifting toward rapid whole exome or whole genome sequencing is fast becoming the standard of care to catch those genetic etiologies before critical developmental windows slam shut.
Okay, Section 3, self-limited neonatal syndromes, focusing on the familial channelopathies. Look at how these two main self-limited syndromes contrast. They're both primary channelopathies, usually autosomal dominant, but they operate through completely different mechanisms. We have CELNI, usually driven by KCNQ2 or KCNQ3 mutations, affecting voltage-gated potassium channels. When those channels misfire, you get impaired repolarization causing hyperexcitability. This strikes incredibly early, days 1 to 7 of life, mostly presenting with focal tonic seizures and autonomic signs like apnea. Then, on the flip side, we have CEL-FNIE. This is typically driven by SCN2A mutations, which encode voltage-gated sodium channels. Mutations here also cause hyperexcitability, but the onset window is way wider, anywhere from day 1 up to 21 months. And while you'll see focal tonic seizures, they frequently generalize into clonic activity too.
But here's the absolute must-know for when you're actually on the floor. CELNI is primarily a diagnosis of exclusion. You've got to rigorously check every single box on this list. Focal tonic features? Check. Completely normal interactal neuroexam and head circumference? Check. And pay close attention to this one, a completely normal non-lesional brain MRI. Really take a minute to confirm that read, because if there's even a tiny lesion, maybe a subtle focal cortical dysplasia, scratch that diagnosis. You are dealing with a totally different entity.
Let's move into Section 4, epileptic encephalopathies, or DEEs, the severe neonatal epilepsy syndromes. Your clinical radar should absolutely go off for a DEE if you've got a seizing newborn with no obvious acute cause, especially if they are globally encephalopathy or their interictal EEG is showing a devastating burst suppression pattern. These are catastrophic syndromes. Both the underlying genetic etiology and the relentless seizures themselves directly cause profound neurodevelopmental delays. Just think about the developing brain under that kind of stress. The continuous firing disrupts synaptogenesis, alters neural circuits, and essentially steals the brain's developmental energy. It leads to irreversible cognitive and motor impairments.
These clinical presentations are just brutal. With early infantile DEE or EDE, you're looking at frequent, highly refractory seizures coupled with obvious early developmental impairment. The encephalopathy is profound. Then there's KCNQ2-DE. These babies present almost always in the first week of life with deep encephalopathy, severe hypotonia, a lack of visual attentiveness, and seizures that just shrug off standard initial treatments like phenobarbital. Both of these will light up an EEG with highly abnormal background patterns, from multifocal discharges to frank burst suppression.
And that brings us to a massive clinical pearl. You probably noticed the KCNQ2 gene just popped up again. A KCNQ2 variant does not automatically mean a benign course. Depending on the specific pathogenic variant, like a severe de novo missense mutation, it can manifest as a catastrophic KCNQ2-DEE instead of the benign CELNA. It's wild, right? This is exactly why precise genetic testing, interpreted strictly within the context of your patient's actual clinical picture, is absolutely vital for giving families an accurate prognosis.
Finally, Section 5. Treatable metabolic epilepsies, acting specifically on the lysine degradation pathway. Here we're talking mainly about pyridoxine-dependent DE and pyridoxamine 5-phosphate oxidase deficiency DE. Yes, they're rare, but they are highly actionable genetic disorders. The core issue is a metabolic defect in the lysine degradation pathway. You look for biomarkers like elevated alpha-ASI to aid the diagnosis. Basically, mutations in genes like ALDH7A1 cause a profound enzymatic block. This block leads to the buildup of intermediates that actually deplete the active form of vitamin B6. And since B6 is a crucial cofactor for synthesizing GABA, the brain's main inhibitory neurotransmitter, the brain loses its brakes. Without GABA, it just seizes uncontrollably. But because we know exactly where this block is, we have a life-changing pharmacological workaround.
So if standard anti-seizure meds are doing absolutely nothing for your neonate, you must consider this protocol. You're going to bypass that block and restore GABA synthesis by administering a therapeutic trial of IV pyridoxine. But listen closely to step 2. You must do this in a strictly monitored setting, ideally with full resuscitation equipment right at the bedside. Why? Because while IV pyridoxine can miraculously stop the seizures, there's a very real risk of sudden, profound cardiorespiratory collapse and apnea during that initial test dose. You have to be ready to manage their airway.
We've covered a ton of crucial ground today, right? From rigorously clearing out those acute symptomatic causes, down through the complex channelopathies, all the way to those highly treatable metabolic pathways. So after navigating all of that, the ultimate question for your daily practice is this. When that standard workup comes back completely negative, are you prepared to look beyond the obvious, identify, and effectively treat that crucial 10%? Thanks for hanging out with me on this explainer, and I really hope this diagnostic framework serves you and your patients well on your next